Hello everyone. Today we are going to learn few things about monitoring and anesthesia. Myself, Dr. Bhakti Bhndari, Junior Resident from Department of Anesthesiology and Critical Care. Introduction. In recent years, several risk factors for adverse outcome in patients undergoing anesthesia have been identified. Besides human errors, cardiovascular and respiratory complications are associated with substantial morbidity. Assessment of complications has promoted the introduction of basic physiological monitoring in clinical practice. Whether monitoring directly affects outcome is not proven. However, circumstantial evidence suggests that basic cardiorespiratory monitoring decreases the incidence of serious accidents. Prevention of hypothermia also reduces anesthesia related morbidity. Measurements of body temperature is mandatory and active warming is simple, effective technique to avoid hypothermia. Evidence is growing that patients with known or suspected coronary artery disease should be treated with beta blockers perioperatively, whether the type of anesthesia, that is, general or regional, is relevant to perioperative mortality remains unclear. In subgroups of patients at high risk, neuraxial anesthesia reduces the rate of respiratory and cardiovascular complications. These are few basic monitoring techniques we are going to learn in next few time. Monitoring means to be aware of the state of system, observe the situation for any changes which may occur over time using a monitor or measuring device of any sort. In anesthesia, monitoring aids to know when to make therapeutic intervention and to guide the assessment of those interventions. Monitoring. It includes basic monitoring and advanced monitoring. Basic monitoring. Basic monitoring means clinical monitoring. It includes pulse rate, color of skin, blood pressure, inflation of chest, precordial and esophageal stethoscopy, signs of sympathetic overactivity, and urine output. Advanced monitoring, which includes instrumental monitoring. First, cardiovascular system monitoring. Cardiovascular monitoring includes non-invasive techniques, invasive techniques, and semi-invasive techniques. First, the heart rate monitoring. Finger on pulse is the easiest and quickest method to assess the heart rate. ECG is the most common method to detect heart rate in OT by measurement of RR interval. ECG can get confounded by electrosurgical instruments, ball line noises, twitching and fasciculations, lithotripsy machine, cardiopulmonary bypass, and fluid warmers. Direct ECG monitoring is better than monitoring of derived heart rate. ECG. Mandatory monitor to detect arrhythmia, ischemia, or cardiac arrest. Significance of ECG. ECG gives information about rate and rhythm of the heart, physical orientation of the heart, that is, axis, diagnostic tool for various heart conditions like hypertrophies, ischemia, infarction, arrhythmia, conduction problem, and pacemaker activity. ECG does not provide information about mechanical activity. Second technique is non-invasive blood pressure monitoring. Measures blood pressure at set intervals automatically by automated oscillometry. Cuff size should cover two-thirds of arm. Small cuff for children. Too large cuff underestimates while too small cuff overestimates the blood pressure. Complications of non-invasive blood pressure measurement. It includes pain, fatigue, and ecchymosis, lymphedema, venous stasis and thrombophlebitis, peripheral neuropathy, or compartment syndrome. Invasive monitoring includes invasive blood pressure monitoring, central venous pressure monitoring, and pulmonary artery catheterization. Invasive blood pressure monitoring. Here we use arterial line for blood pressure monitoring. Indications. Hemodynamic indications include blood pressure when it is very labile, where hemodynamic instability is anticipated, where hemodynamic therapy is being titrated. Example, patients in whom vasoactive drugs like noradrenaline infusion has been started, where non-invasive blood pressure monitoring would be inaccurate or unreliable, for example, in context of arrhythmia or morbid obesity. Blood sampling techniques, where respiratory therapy such as mechanical ventilation is being titrated, where frequent biochemistry testing is required and venous sampling is difficult. Diagnostic or interventional procedures, intra-arterial drugs, endovascular procedures, intra-aortic balloon counterpulsation, arterial embolization, and conditions where continuous cardiac output monitoring is required. Absolute contraindications include absence of collateral circulation, example, in abnormal modified Allen's test, local infection, distorted anatomy, example, in previous surgical interventions or congenital malformations, active Raynaud's disease, thromboangiitis obliterans, burn cases, aneurysms, stains, or synthetic vascular graft, arteriovenous malformation, or AV fistula cases. Relative contraindications include severe peripheral vascular disease, severe coagulopathy, when INR or APTT values are severely deranged, severe thrombocytopenia, recent use of thrombolytic agents. The Allen's test. This is a traditionally well-known procedure done prior to the insertion of radial arterial catheter. The goal of this test is to provide assurance that the collateral ulnar arterial blood flow is sufficient to avoid distal ischemic injury. Both radial and ulnar pulses are occluded forcefully by manual palpation for 10 to 15 seconds or until the blanching of palm are noted. The ulnar arterial occlusion is released. If blanching resolves quickly, the patency of ulnar artery is enough to perfuse the hand in spite of complete or partial occlusion of radial artery. This is how the Allen's test is performed. If the perfusion of hand is seen within 7 seconds, the test is normal. If it takes 7 to 14 seconds, Results are borderline. If it takes more than 15 seconds for perfusion of the hand, arterial catheterization is contraindicated. Cannulation complications include arterial injury, spasm, distal ischemia, thrombosis, embolization, sepsis, tissue necrosis, fistula, and aneurysm formation. Prevention: continuous flush with or without heparin. Next technique of invasive monitoring is central venous pressure monitoring, in which we use CVP line for monitoring of cardiovascular system status. Central venous line or a catheter. A central venous catheter is a special IV line that is inserted into a large vein in the body. Several veins are used for central venous catheter, including those located in shoulders. Lavian vein, neck, includes jugular vein, and groin, that is femoral vein. Indications: there are many different indications for placing CVL, that is central venous line. But in emergency medicine, the most common indications include fluid resuscitation, including blood and blood products, drug infusions that could otherwise cause phlebitis or sclerosis, example, vasopressors and hyperosmolar solutions, central venous pressure monitoring, pulmonary artery catheter introduction, emergency venous access due to difficult peripheral IV access, transvenous spacing wire assessment, placement. Contraindications. Contraindications include distorted local anatomy such as COMA, infection overlying the insertion site, or thrombus within the intended vein. Relative contraindications include coagulopathy, hemorrhage from target vessel, suspected proximal vascular injury, or combative patients. Equipments: we need syringe and needle for local anesthetic, small vial of 1% or 2% lignocaine, syringe and introducer needle, scalpel, guide wire, tissue dilator, sterile dressing, suture and needle, central line catheter, of which there are several types, including triple lumen, double lumen, and large bore single lumen. In addition, the operator will require a sterile gown, cap, sterile gloves, sterile gauze, sterile saline, face mask, and a sterile cleansing solution, such as chlorhexidine. The operator should ensure that sterile ultrasound gel, and a sterile ultrasound probe are part of setup as well. The steps are as follows. First, we have to infiltrate the skin with 1% lignocaine for local anesthesia around the site of needle insertion. Use bedside ultrasound to identify the target vein whenever possible. If using landmark for subclavian vein central venous line, the needle should be inserted approximately 1 centimeter inferior to the junction of middle and medial third of the clavicle. If using landmarks for femoral line, the needle insertion site should be located approximately 1 centimeter to 3 cm below the inguinal ligament and 0.5 cm to 1 cm medial to where the femoral artery is pulsated. Insert. Introduce a needle with negative pressure until venous blood is aspirated. For the subclavian central venous line, insert the needle at an angle as close to parallel to the skin as possible until contact is made with the clavicle. Then advance the needle under and along the inferior aspect of the clavicle. Next, direct the tip of the needle towards the suprasternal notch until venous blood is aspirated. Whenever possible, the introducer needle should be advanced under ultrasound guidance. Ensure the tip does not enter the incorrect vessel or puncture through the distal edge of the vein. Once venous blood is aspirated, stop advancing the needle. Carefully remove the syringe and thread the guide wire through the introducer needle hub. While still holding the guide wire in place, remove the introducer needle hub. If possible, use ultrasound to confirm the guide wire is in target vessel in two different views. Next, use scalpel tip to make a small stab in the skin against the wire just large enough to accommodate the dilator and eventually the central venous catheter. Insert the dilator with a twisting motion. Advance the line over the guide wire. Make sure distal lumen of central line is uncapped to facilitate passage of guide wire. Once central venous is in place, remove the guide wire. Next, flush and aspirate all ports with sterile saline. Secure the line in place with a suture and place sterile dressing over the site. Central venous pressure is increased in fluid overloading, congestive cardiac failure, pulmonary embolism, cardiac tamponade, intermittent positive pressure ventilation with P, constrictive pericarditis, pleural effusion, pneumothorax, coughing, and straining. While central venous pressure is decreased in hypovolemia and shock, venodilators, spinal or epidural anesthesia, general anesthesia by causing vasodilatation. Whenever the central venous pressure and blood pressure, both the values are low, the cause is hypovolemia. When central venous pressure is high but blood pressure is low, the cause is pump failure. X-ray chest. X-ray chest is performed to check the position of catheter and to exclude the pneumothorax, which can be the fatal complication of central venous catheterization. Complications of central venous line or central venous catheterization include air embolism, thromboembolism, cardiac arrhythmias, pneumothorax, hemothorax or chylothorax, cardiac perforations or cardiac tamponade, sepsis or trauma to brachial plexus, carotid artery, phrenic nerve or airways. This is the X-ray which is showing line placement in internal jugular vein. Next method in invasive cardiovascular monitoring includes pulmonary artery catheterization. It is reserved only for very major cases in severely compromised patients because of cost, technical feasibility, and complications associated with it. Swan-Ganz catheter is balloon tipped and a flow directed by pressure recording, pressure tracing, and catheter tip, indicated by sudden rise in diastolic pressure. Swan-Ganz catheter or pulmonary catheter provides diagnostic information to rapidly determine hemodynamic pressures, cardiac output, and blood sampling for mixed venous oxygen saturation. Measures central venous pressure, pulmonary artery pressure, and cardiac output. Indications include some diagnostic and therapeutic terms like post-MI patients, cardiac surgery, or patient undergoing a major elective or emergency surgery, resuscitation, patient in shock, patients with pulmonary edema, and who requires oxygen transport, ventilation, and perfusion. Conclusion: CVP measures in the vena cava. Its value is related to the volume of blood in the veins and it's approximately the right arterial pressure. PCWP, that is pulmonary capillary wedge pressure, measured by advancing a catheter through pulmonary artery until it wedges in the artery smallest branch. At that point, the catheter senses pulmonary capillary pressure, which is nearly equal to left atrial pressure. Indications: measuring cardiac chamber pressures except left ventricle pressure, calculating cardiac output, measuring pulmonary artery occlusion pressure, taking sample for mixed venous blood, titration of fluid infusion. Respiratory monitoring. Respiratory monitoring includes pulse oximetry, capnography, blood gas analysis, lung volumes, oxygen analyzers, airway pressure monitoring, and apnea monitoring. Pulse oximetry based on the light absorption characteristics of hemoglobin. Oxygenated hemoglobin absorbs more infrared light and allows more red light to pass through, while deoxygenated hemoglobin absorbs more red light and allows more infrared light to pass through. This is called as Beer-Lambert's law. Sources of error in oximetry are ambient light, low perfusion states, motion artifacts, external dyes, carboxyhemoglobin, and saturation below 80%. Capnography. It is the continuous measurement of end-tidal carbon dioxide, that is, EtCO2, and its waveform. Normal value is 32 to 42 mmHg, which is 3 to 4 mmHg less than arterial PCO2, which is 35 to 45 mmHg. Principle is infrared light absorbed by carbon dioxide. It is very important and sensitive technique of monitoring. These are few waveforms which are used for assessment of status, who is under anesthesia or who is undergoing mechanical ventilation. Sudden loss of waveform includes PT tube disconnection, dislodgement, kinking, or obstruction, or it can be due to loss of circulatory function. Decreasing ATCO2 train includes ET tube cuff lick, ET tube placement in hypopharynx, or partial obstruction. Next waveform is suggestive of CPR assessment to maintain minimum of 10 mmHg of end tidal CO2 value. Sudden increase in EtCO2 indicates that there is a return of spontaneous circulation. Next graph suggestive of shark fin appearance is seen in bronchospasm. Conditions include asthma and COPD, which means chronic obstructive pulmonary diseases. Next graph is for hypoventilation. Next waveform suggestive of hyperventilation. Decrease in EtCO2 train. Value of waveform suggestive of apnea or sedation. Next thing, which is very important for assessment of respiratory status, is blood gas analysis. Following precautions are to be taken while we take sample for blood gas analysis. Glass syringe is preferred for sampling. Syringe should be pre-heparinized. Sample should be stored in ice. Sample from radial or femoral artery is to be taken. These are normal values on room air. pH 7.38 to 7.42. Normal PO2 value is 96 to 98 mmHg. Normal value of PCO2 is 35 to 45 mmHg. Normal value of HCO3 is 24 to 26 milliequivalent per liter. Normal value of SpO2 is 95 to 98%, while normal value of base deficit is -3 to +3. Temperature monitoring. Temperature monitoring is essential part because there are high incidences of intraoperative hypothermia which can lead to severe fatal complications. These are usually seen in major cardiac surgeries, infarcts, burn cases, febrile patients, and patients who are pre-diagnosed with malignant hypothermia. These are few core temperature monitoring sites, which includes esophagus, pulmonary artery, nasopharynx, and tympanic membrane, which is the most accurate site for brain temperature measurement. Hypothermia, when core temperature is less than 35 degrees Celsius. Mild hypothermia, when temperature is between 28 to 35 degrees Celsius. Moderate hypothermia is when temperature is between 21 to 27 degrees Celsius, and severe hypothermia when temperature is below 20 degrees Celsius. These are few systemic effects of hypothermia. Cardiovascular system includes bradycardia, hypotension, ventricular arrhythmias. Respiratory system includes respiratory arrest when temperature is below 23 degrees Celsius. O2 dissociation curves is shifted to left. There is an increase in blood viscosity and platelet count. Acid-base balance disturbance like increased solubility of blood gases, and acidosis. There's a decrease in GFR and no urine output at temperature 20 degrees Celsius or below than that. Endocrine system defects include decrease in adrenaline and noradrenaline and hyperglycemia. Next and foremost important point is CNS monitoring, which includes neurologic recheck, level of consciousness like person, place, and time orientation, motor functions, pupillary response, vital signs, and Glasgow coma scale. Motor functions includes ability to follow commands, muscle tone, muscle strength, coordination, balance, posturing. Level of consciousness, whether the patient is alert or responding to verbal stimuli or responding to painful stimulus or totally unresponsive. Next is a Glasgow coma scale. This scale is very important in patients with a head trauma for assessment of consciousness and orientation. In this scale, we use 3 points: eye opening response, verbal response, and motor response. Total score is 15. The best score is 15 by 15 when patient or a person is totally conscious oriented, responding to all the stimulus and obeying all commands. When patient's score is less than 8, it is comatose and indicative of bad sign which requires a mechanical ventilation. When the score is 3, that is, the patient is unresponsive. There is no eye opening, no verbal response, and no motor response to any kind of stimulus. Eye opening response include 4 points: spontaneous eye opening to speech, eye opening to pain, and no response. Verbal response include 5 points: orientation to time, person, and a place. 4 points when person is confused. 3 points when inappropriate words. 2 points for incomprehensible sounds. And 1 point when there is no verbal response. Motor response includes 6 points. 6 points when the person obeys commands. 5 points when moves to localized pain. 4 points when he flicks to withdraw from pain. 3 when there is abnormal flexion. 2 when there is abnormal extension. And 1 when there is no motor response. Pupillary changes. Oculomotor response, which is due to cranial nerve 3. Size, equality, and roundness of pupil is assessed. Size measured in millimeter. Evaluated for symmetry in size and response to light stimulus. Brisk, sluggish, or non-reactive pupil. Or consensual reaction of opposite pupil at same time. This changes or this test is very important in any patient who has undergone any cranial surgery, patient with any intraparenchymal or intracranial bleed, or the patient with a head trauma. Monitoring depth of anesthesia. Following are signs and symptoms of light anesthesia: tachycardia, hypertension, lacrimation, perspiration, tachypnea, breath holding, coughing, laryngospasm, bronchospasm, and eye movements. Whenever we see these few points clinically or whenever we observe these signs and symptoms, it indicates that the patient is in light anesthesia plane. Next important point is monitoring of blood loss. Estimation of blood loss is done by way blood-soaked swabs, sponges, and blood loss in suction bottles. On an average, fully soaked swab is considered as 10 ml. Fully soaked sponge is 100 to 120 ml. Fist of clots means 200 to 300 ml. Monitoring of blood loss is very important in anesthesia or in any patient undergoing a major surgery or any geriatric or pediatric patient, as hemodynamic assessment can only be estimated or major changes in blood pressure or a pulse volume is estimated by using blood loss monitoring. These are examples of some multi-para patient monitors showing ECG, heart rate, temperature, blood pressure, CVP line, end-tidal CO2 values, and many more functions which are very essential and important for monitoring of any patient who is under anesthesia or who is going to undergo any mechanical ventilation under general anesthesia or any sort of regional anesthesia. Thank you. I hope you have enjoyed this lecture and understood some basic points in monitoring of anesthesia. Thank you.